Good afternoon. My name is Ram Ramachandran, and I'm the director for the Johns Hopkins Education and Research Center in Occupational Health, which is situated in the School of Public Health. And it's one of 18 such schools around the country. Um, and it's funded by the National Institute for Occupational Safety and Health. And so today it's my great pleasure to introduce Dr. John Howard, who is the director of the National Institute for Occupational Safety and Health, to deliver the keynote presentation. Just a few notes about Dr. Howard. He was trained as a physician and as a lawyer and as a public health professional. He has an MPH. And he's also got an MBA. So he's perfectly qualified for this sort of interdisciplinary thing we are all launching on. And he is part of the Supreme Court Lawyers Bar. In 2002, he was appointed as director of NIOSH, and he has been appointed to this position several times now, and I think he's the longest serving director of NIOSH in its history. During his tenure, NIOSH has taken on several very important and influential initiatives. He has this great emphasis on research to practice, meaning that NIOSH is not just a research institute, but its findings have a bearing on the practice of occupational health. He has championed occupational health issues and emerging technologies, and more relevant to this particular audience, he has been very important in championing the cause of total worker health, and has started a program in it and has several centers funded around the country through this program. And so I could go on, but I'm getting the hook here. And also, I think you would rather hear from Dr. Howard. So with that, I'll turn it over to John Howard.
Oh, thank you.
Forward and back.
Are the slides going to come up?
They are. Just forward and back.
I just hit forward. Okay, there they are. All right. Well, thanks very much for inviting me. When Ram first invited me, I said, I can't read music, and I don't play an instrument, and I can't carry a tune in a bucket. So I'm not sure I'm qualified to speak to musicians, but I am qualified to talk about prevention. There's two major branches of medicine. One is rescue medicine, all those things that clinicians do to rescue all of us from our genetic, age-related, or individual behaviors, otherwise sin. That's what I call it. So, and then there's preventive medicine, which is an entirely different kind of medicine. And that kind of medicine ends up in a lot of strange places, because the causes of acute and chronic disease happen in very strange places. As an example, when I was director of the California OSHA program, the Occupational Safety and Health program, we had a program in which we looked at the workers' compensation experience modification rates for employers. In other words, it's a way of saying, how many injuries do you have that you're paying for that we as an insurer are insuring you for? And the state of California said, we're going to go after those employers and we're going to help them, okay? We're going to help them. So they gave that responsibility to my program, and I got an interesting education in what it means to be a professional and to do professional activities versus all the other stuff that the rest of us do, like me working in a government office. My first contact was with a group in Oakland, California. They had a very high experience modification rate. And I said, well, I'm here to help you. I'm from government. I'm here to help you. And I went to visit them on the first day, and I thought I was in the wrong place because I ended up in the Oakland Coliseum. They were the Oakland Raiders. And I had really nothing, I thought, to offer that employer about decreasing their injury rates. And as I began to talk to them about some of their more florid injury rates to some of their players, I said, well, can't you just take that guy out of the line. No, we can't take that end out of our line. So the next employer I had was the LA Philharmonic, which those are our employees, okay? And the football players are employees. They're not independent contractors. They're not volunteers. Therefore, they are in that employment relationship of an employer and an employee. That was even worse than the football team because as I began to talk to them about one of their violinists and her issues relative to her musculoskeletal injuries, which kept reoccurring, I said, well, can't you just replace our first violinist? Are you out of your mind? So my experience in trying to help on the prevention side was off to a very bad start based on that experience. But I've gotten better over the years, and certainly for us at the National Institute for Occupational Safety and Health, we support all of the activities that you're doing here today, all of the items. I was particularly drawn to item 14 because it sounded more prevention-oriented than some of the other items that were more clinically oriented. So I wanted to just give you a brief little tour around what occupational health really is, and to give you some basic building blocks that we in NIOSH believe in. Work does matter, and it matters for some people more than others. People often do a lot of different jobs, and they go from one industry sector to another industry sector. That does not seem to be true in the musician's era, whether you're vocal, whether instrument, or whatever. It seems to be a life calling. And some professions are like that. Health matters to be able to do that calling. So if you do not have your health, as we know, you really can't continue work, and that can be a very difficult thing to adjust to. And injuries, acute injuries and chronic diseases from work are very costly for the healthcare system, for the individual if they're not insured, and they're costly for the nation's economy. And policies, public and organizational policies, worker policies, workplace policies, employer policies are necessary, but they're not necessarily sufficient. What I mean by that is that there needs to be something more than just the paper that a policy is written on. It has to be enforced, it has to be paid attention to, it has to be believed in, and it has to be worked. Employers and employees, workers make choices individually and as organizations. Employers often make those choices, as you know, based on economics. And whatever organization that a musician is attached to, there can be economic decisions that are untoward towards the individual. Risks and benefits of work aren't evenly spread out through the working population. We can see certain injuries take place in certain occupations more than others. I think the good associated with work is you get paid for it, which you need to support yourself. You can get access in this country. A lot of our health benefits, 89% of our health benefits are tied to our employment. Not so in Europe, where you have to be a citizen of a country and you get health. No, we have to have employer-based health insurance. Very difficult situation. Social supports are extremely important. People we work with, etc. They enhance our own personality and enjoyment. Work gives us purpose and meaning, and it gives us opportunity to grow personally and in our profession. The bad, of course, and as we look closely from an occupational health perspective at the hazards associated with types of work, and it doesn't matter here whether we're talking about a construction worker or a laborer who goes into an unshored trench, the trench collapses and they're buried. It's the same issue. The hazard is an unshored trench. The hazard that we see here associated with physical injuries are largely, as we have been talking about here in this conference, for folks that use their hands and their fingers to play their tool in the occupational safety and health sense. tendinitis is significant. For those that use their larynx as their instrument, vocal issues are significant. Noise issues. You don't have to play for Metallica to have hearing loss issues associated with a musical career. And there are infectious hazards associated with cleaning instruments, and there is a instrument hygiene that's important. Other hazards we've spoken about earlier today. People talked about the psychological issues associated with being in a group. Groups sometimes engage in bullying and other types of violent behavior. Individuals who are dedicated to their profession and their job can experience burnout. You don't have to be a nurse during COVID-19 to experience burnout in other professions. Depression, sleep disruption, anxiety, heat exposure for musicians that play outside in Coachella. For instance, we've had several incidents in California of musicians having heat exposure issues, and one with heat stroke a couple years ago. Job insecurity associated with any job is common in this area. And I just wanted to drill down on some data that I think is pertinent to some of these things that I just talked about. In terms of injuries, if you look at the research in this area, worker comp data and others, 93% of professional musicians experience playing-related injuries during their career. So it's going to happen to the individual. What are we doing to prevent that from happening to nearly 100% of instrument playing workers? Hearing loss. Clearly, as I said, professional musicians are at risk of contracting hearing disorders. There's lots of literature on that issue. Psychological disorders, there's literature suggesting that musicians are at risk for various psychological disorders, especially anxiety disorders associated with either having a personality trait that's oriented, a performance anxiety issue, or just the social anxiety of being around a lot of people. The issue about musculoskeletal conditions I can't really emphasize enough. This is data from Australia, primarily. Nearly 70% of workers' comp claims in Australia are due to musculoskeletal conditions, 50% of which were for upper limb conditions. Musculoskeletal conditions accounted for nearly 80% of the costs that are associated with musicians' worker comp claims. And the most common mechanism for musculoskeletal claims in musicians is body stressing, the idea you're having a fight or flight type of reaction. And the most common agency or instrument, et cetera, was non-powered equipment, which is obviously the musical instrument. This is the way workers' comp classifies these injuries. And so this is significant in the sense of, again, musculoskeletal disorders being so prevalent within this community. And just remember, when you start out in the general working population, this is data from the Bureau of Labor Statistics, a third of American workers experience an injury involving days of work, days away from work. A third have workers' comp costs associated with those injuries, and these types of musculoskeletal disorders are number one as a global disease burden. So it is very significant. We concentrate on how do we prevent musculoskeletal injuries in these individuals. The ugly part, where if we fail to do the prevention steps that are important for this job category, where we have people with lost income and all of these deleterious things we've spoken about here today. I've heard lost productivity, increased turnover in terms of the jobs that you get, reduced employment options based on your history, healthcare costs, which often are exceeding your benefits. Opioid use is not that uncommon in any individual that has chronic musculoskeletal disorders, because what happens frequently, and certainly it was a scourge in 2012 through 2016, 17, even today, most workers' comp physicians that you end up going to, because your insurer will send you to that physician, end up giving you pain medications. And before there was opioid prescribing rules that we adopted at CDC, this was the most common drug used. Opiates were the most common drugs used in the Florida worker compensation system, for instance, for the past 10 years. What happens then is that you get substance use disorders associated with pain medications from a musculoskeletal injury. So you have a cascading problem from an original failure to prevent the MSD. Suicide risks can occur in burnout situations where someone has lost their career, they may on substance use, etc. Just a little slide about the approach that we take in occupational medicine to anticipate what the hazard could be in that particular type of profession or work, and recognizing what that hazard is, the contours of it, the frequency of it, the duration of it, and then evaluate what we can do to eliminate or somehow mitigate that particular issue by putting in a control or mitigation strategy, some kind of intervention, and then evaluating the intervention for effectiveness. So the way in occupational safety and health we've put this all together as an example, some of you may have seen this before, is a hierarchy of controls, where we have said and practiced that elimination of the hazard is our first step. And obviously, in many workplaces, that can occur. A very toxic chemical. Just get rid of that very toxic chemical and get a green chemical, for instance. Substitution, replacing that hazard. The issue about putting an engineering control, a hearing device on someone who is jackhammering in the street is a type of engineering control, so to speak. It's also an administrative control type where you rotate somebody through a hazardous environment, so you're not spending as long a time in it, you're decreasing the risk. And then PPE classic, a respirator put on, a healthcare worker wearing a respirator during COVID-19 as an example. So what we've done, as Rob mentioned, is to try to bridge in the occupational health and preventive medicine world between just promoting good behaviors that are lifestyle related, that are individual behavior related, for instance, smoking cessation, diet intake, weight control, etc., with health protection, standard occupational safety and health practice, where we're actually doing all those things like eliminating, substituting, and using administrative controls and PPE. And this is a large group of issues that we've decided, if you look at all of these types of issues, if one of these or more of these issues are present in your workplace, then you have to address them, because otherwise you're not providing total worker health, which is both health promotion to prevent hazardous behaviors and eliminating the hazard from the workplace that's caused by work itself. So in the total worker health hierarchy of controls, we've used the example in the eliminate category of taking working conditions that threaten safety, health, and well-being, and trying to eliminate them from the work. Substituting health-enhancing policies instead of the hazardous policies, redesigning the work environment, educating workers about the safety and health practices, and then encouraging personal change. Clearly, for the musician environment, this type of total worker health paradigm would have to be adapted to a particular musician's environment in terms of what can be done in that environment. I think the benefits are clear. One would, if one practiced this type of preventive medicine approach, the total worker health approach, for musical industry sectors, higher overall satisfaction, better mental health, lower burnout. Clearly, I think you would get more satisfaction by the individual and by the organization that the individual works for. And clearly, I think you would probably see interventions that are focused on specific aspects of the musical industry, no matter which particular part it is, that are relatable to the individual who participates in that industry. That is really key to success in terms of using total worker health. This is an example of one kind of strategy that we recommend. This is a worker well-being questionnaire that we developed and have used hundreds of times. It's free for public use. You can just look at that URL and get it. And we've benchmarked it for various occupations, industries, and workforces. One can use it to examine changes over time, to look at the impact of an intervention that you've put in place. Is it working? Is it not? Comparing results between groups that maybe have used the intervention, but another group that hasn't, sort of a case control kind of methodology. And you can share your data then with the HERO Working Wellbeing Clearinghouse, which is a large clearinghouse of all of this type of information. We really encourage folks to use this tool that are trying to implement some changes in the workplace. So thank you very much again for inviting me here, and I certainly support all of your items that you talked about in the previous session, and I think you're off to a great start. So thank you very much. All right, what's next?